Welcome to hematologic problems. These are your objectives. Platelets, thrombocytes. Platelets typically live up to 28 days, if not longer, in the body. And a normal platelet count is from 150,000 to 400,000. So we have a wide range of platelets. And even if the platelets get below 150,000, it is very rare that we're going to infuse platelets unless we're going to surgery and the patient is on blood thinners. Anemia. Anemia is the number one hematologic issue that we have in this country. Majority of individuals that have anemia are female patients. It is deficiency in the number of erythrocytes, hemoglobin, and hematocrit. And remember, very, very common for anemic patients with a low hemoglobin and hematocrit count to be hypotensive and to be tachycardic. Very, very normal to see. Again, clinical manifestations, vital signs, like I just said. Patient's going to be hypotensive, and then they're going to be tachycardic. They also can have shortness of breath if it is severe from the lack of RBCs carrying oxygen in the bloodstream. So there is a very wide amount of symptoms of anemia. The most common ones we see are tiredness, fatigued, weakness. If we have a patient that has severe anemia to the point where they are fainting or having chest pain, this patient needs a blood transfusion. Their heart and other internal organs could be shutting down. Erythrocyte production. RBCs last to about 120 days in the body. That is going to be important when we talk about treatment of anemia. So iron deficiency anemia, very common again we see in our country. The hemo count is for about 2/3 of the body's iron. So if our RBCs are low, we're not going to have enough iron in the bloodstream. So some different etiologies for having iron deficiency anemia. Something we do see is an inadequate dietary intake of iron, possibly malabsorption, so someone with a GI malabsorption, so GI cancer, diverticulosis, diverticulitis. Blood loss, this is usually a chronic, steady blood loss. Individuals that have menses that are very long and heavy. Hemolysis, the body's inability to have clotting factor. And then a lot of times individuals that are pregnant will have iron deficiency anemia. That little one just takes everything from you. So iron deficiency anemic patients, again, they can be fatigued and tired. They can have shortness of breath from the lack of RBC iron count. They have pallor, so their skin is more pale. And then they can have swelling of the lips and the tongue, which is a telltale sign of iron deficiency anemia. So how do these get diagnosed? Biggest one we do is a CBC. CBC is going to tell us the hemoglobin and the hematocrit count, the RBC count, and the platelet count. So it's going to be a one-stop shop for finding out if the patient's anemic or not. If they are anemic, then we do want to find out why they are anemia, why they have anemia. If we don't have a clear sign, the physician may want a stool guaiac test to see if there's any blood in the stool. If there is, the patient could be scheduled for an endoscopy or a colonoscopy or both to see if there's a minor GI bleed or an extensive GI bleed going on. Bone marrow biopsy would be the last item. And if we're looking for a bone marrow biopsy, we might be looking for leukemia. We'll talk about that in a minute. So how do we care for iron deficiency anemia? Now, we'll talk about medications in a moment. But if someone's underlying goal is to treat their iron deficiency anemia with food. This is just a very small scale on the foods out there that are high in iron. Red meats are high in iron, poultry, a lot of different fruits and vegetables, and grain. So an individual does have the capacity of increasing their iron content through their dietary intake if they so choose. If they want to increase diet and take a supplement, oral supplements are the most common that individuals can take, and you can get iron supplements, Walgreens, CVS, Walmart, Target, probably at Quick Trip these days. If it is severe, we can do IM or IV. Be careful because both of those options do stain the skin if spilled. And remember how I said RBCs can take up to 120 days to live through the body? If somebody is going to change their diet to increase their iron, or they're going to take an oral supplement to increase their iron, they do need to give their body 3 to 4 months to actually have the full effect. It will not be something that they see right off the bat. They also need to be educated on the side effects. Iron supplements can cause GI constipation and can make the stools dark and tarry, which can mimic GI bleeds. We have to make sure we let the patients know that is a common side effect and they do not have to give us a call. So acute blood loss. Acute blood loss is not something we see a whole lot, to be honest with you. We see it in trauma patients and complications of surgery. We can see it in different disease processes that are affecting the heart and hypovolemic shock. So again, acute blood loss patient, their blood pressure is going to go low, they're going to go hypotensive, and their heart rate and their respiration rate are going to go high, and it can happen very, very suddenly. The first thing we're going to give a patient with acute blood loss is going to be actually isotonic IV fluids because we want to get their volume up to prevent shock. But then as soon as we can get the blood products in, we should be infusing them. Then we want to identify the source of the hemorrhage and then stop the bleeding. Sometimes this does involve surgery and is a very rapid process to get that patient back into surgery, especially after a car accident or some type of trauma. Chronic blood loss is for an individual that has chronic daily loss of blood outside the circulatory system. So this could be bleeding ulcers that either they are aware of or not. Hemorrhoids. Hemorrhoids can cause quite an issue for some people. Menstrual or postmenstrual blood loss. Again, manage the blood loss, identify the source, reduce or stop the bleeding if possible, and provide iron supplements or increase iron-rich foods as needed. Sickle cell anemia. Sickle cell anemia is a group of inherited recessive disorder. This is predominantly seen in population for African American, but can be seen in any population. It is incurable, and it can be fatal if not treated in a timely manner and treated chronically. So these are just how the different cells look. On the left side of the screen, that's your normal, nice plump cells. In a sickle cell, you have the oxygenated one. So we want to have patients with sickle cell anemia that are getting enough oxygen and getting enough hydration. We want to keep those cells as plump as we possibly can. And you can see all the way on the right of that picture are the deoxygenated one, and you can really see the sickle celling there. So it is immensely important to get treatment for sickle cell patients going immediately as soon as they hit the ER, or in the case sometimes the EMS, the ambulance. So very common, you'll see the treatment for sickle cell is something called HOP, and a lot of hospitals include the frog with the HOP. And the frog stands for folic acid. So you want to write that down. Frog stands for folic acid. And you need folic acid for good DNA synthesis. So if we plump up the folic acid in the body, they will have a better opportunity of creating non-sickle cell red blood cells. The HOP stands for hydration. So we want to give massive amounts of IV fluids to the patient. Oxygenation, get an O2 mask on the patient. I don't care what their O2 level is. I don't care what the pulse ox says. Get them oxygen on. And extensive pain relief. We are going to be giving this patient a lot of pain medication, IV push pain medication. We're talking about 8-10 milligrams of morphine in one push, 1 to 2 milligrams of Dilaudid in one push. They need the support. They have the sickle cells blocking blood flow to certain parts of their body during a crisis. Their joints will feel like they're on fire. They will not be able to breathe. So do not skimp with the pain medication. Give them what they need. You do not need to worry about memorizing the list of clinical manifestations for sickle cell anemia because it is a blood disorder. It can hurt and affect any limb, any organ, any system of the body. How do we diagnose this? So a lot of things you'll see is called a sickling test or a peripheral blood smear. Basically, it's the same concept. You get a couple of drops of blood, you put it on a glass slide and look it under a microscope. You will be able to see the cells sickle. Once a patient has been diagnosed with sickle cell anemia, physicians like to do MRIs, they like to do skeletal x-rays to see the extent of the damage. So we have a baseline and to see if there's anything else that we need to look at that is causing harm from the sickle cell anemia. A lot of people that have sickle cell anemia have joint issues from all the blockages, and we just want to see how we can help them out with that. So management, collaboration care is directed toward what is specific about each patient. This patient is at high risk for having TIAs or strokes. I know we haven't done neuro yet, but TIA is the small stroke-like symptoms you can get that are resolved. But once a patient has a TIA, they're at a greater risk for having a full-blown stroke. So sometimes these patients are put on low-dose aspirin just to prevent that. As soon as an individual with sickle cell isn't feeling well, we want to target what's wrong. We want very good management of health, whether the patient decides to do vaccines, supplements like vitamins over the counter, folic acid vitamins, increase their iron intake. Those are all things that will help manage sickle cell. But it is not foolproof. And sickle cell anemia patients have crises all the time. And we've got to be ready to act on them and implement the frog hops to get it under control. A lot of times individuals with sickle cell crisis will be hospitalized for IV management, pain management, oxygen therapy. Next one we're going to talk about is polycythemia vera. Polycythemia vera is technically a cancer, though it is not a cancer how you would think of where cancer cells are mutating and attack the body. In this case, this particular cancer is having the body produce way too many RBCs. We don't know why it happens. Thankfully, though, this is easily treated. So symptoms of polycythemia vera are going to look very, very similar to severe anemia. So you don't have enough RBCs or you have too many RBCs, you're going to have very similar signs and symptoms. So I'm not really concerned about that right now. How we diagnose polycythemia vera is a CBC again. If their hemoglobin counts, their hematocrit counts, and their RBC counts are too elevated on a constant level, even if the patient's well hydrated, they could get a polycythemia vera diagnosis. We're also going to look at uric acid levels, B12 levels, and histamine levels that may be contributing to the polycythemia vera. So, treatment. Very common, these particular patients go give blood. They go donate blood. And they can donate blood. I've had patients donate blood 3 to 4 times a month because their body is making so many cells that they don't need. And this manages the polycythemia vera for them very well. They don't need any extra iron. They don't need iron supplements. They don't need to avoid iron-rich foods, but they don't need to purposely put more iron-rich foods or iron supplements into their body. We want to make sure they stay nice and hydrated to keep those cells plump. And very, very often, they're on a low-dose aspirin to help keep things from sticking together. Deep vein thrombosis. So deep vein thrombosis, as we've talked about in the past, is a blood clot that starts in the leg. You don't have to worry about the synonym there. Don't worry about the thrombosis part, okay? So we're more concerned about what the patient's going to look like. They're going to complain of pain in their calf area. The affected calf is going to be bigger than the non-affected calf, so we like to do a quick measurement. The affected calf can be warm to the touch, and there can be fatigue in the leg, so they have a harder time moving that particular leg. So collaborative care. This patient is going to be put on a mild blood thinner. Sometimes we do use heparin. Now remember, blood thinners don't blood thinners do not bust the clots up. They just prevent the clot from getting bigger, and they prevent they prevent more clots from happening. So if there's a patient at a higher risk, we want to do preventative care. Somebody sits a lot at their office, we want to make sure that they're doing leg exercises or push or getting up and stretching and walking around several times during the day. If the patient is bedbound, we want to make sure we're turning them, doing passive range of motion, using TED hose, SCDs, and a lot of times they're going to be on a low dose anticoagulant. Neuropathy. I'm sorry, not neuropathy. All right, slide 30, neutropenia. Neutropenia is the reduction of neutrophils in the bloodstream. A lot of times you'll have patients with leukemia and fighting different cancers on neutropenia precautions because of the low white blood cell count from the chemo and radiation therapy. Now, you do not need to know the different types of leukemia. That is something that if you go into oncology, you'll get trained on more, but that is not an objective for the NCLEX. One of the main symptoms of leukemia is before treatment, they're going to have a very, very high white blood cell count. Normal white blood cell count is anywhere between 6,000 and 11,000, give or take. And it's very common for leukemia patients' white blood cell counts to be above 150,000 before treatment starts. So the reason it's so high isn't because the body has all of these mature white blood cells backed up. It's the reason that once the leukemia is detected by the body is going to release all the little immature white blood cells. Those little guys aren't going to do anything. So the first time a patient gets a dose of chemotherapy, they're going to eradicate all those immature white blood cells because they're not strong enough to survive. And then the CBC count will be able to tell us what the real white blood cell count is. So we put these patients on neutropenia precautions, so reverse isolation, because of the immature white blood cells. Blood transfusion reactions. So the first one we're going to talk about is hemolytic. Hemolytic is the most dangerous and can end in patient death. Hemolytic is caused by an inflammatory response of the body fighting the blood come in. And what happens is it will cause clumping for the RBCs and block arteries and decrease blood flow to vital organs, causing the organs to shut down. Like I said, this is incredibly dangerous, but it is very, very rare. It can be mild, and we can fight it with heparin and different blood thinners if caught. So one of the main patient complaints when there's a hemolytic reaction is the patient will tell you something is wrong. They'll tell you they have a feeling they're about to die. We call that impending doom. They start to have a panic attack. They're very restless. They can have chest pain. They actually get lumbar pain in the lower back because there's decreased blood flow to the kidneys. So the kidneys are going to start to cry out for help first. So again, this is very serious, and this is going to be an ICU patient, and we're going to tackle this patient very, very fast. Allergic reaction. You're going to see allergic reaction much more common. Not as common as febrile, which we'll talk about, but anybody can have allergic reaction to anything. The most common the most common symptom we see is something called urticaria. Urticaria is just a really fancy word of saying hives. So allergic reaction, you're going to get hives, and urticaria is the fancy way of saying hives in the medical field, okay? So the picture on the slide, that is an example of urticaria, and you will see it in the arm where the patient was getting the infusion. Fever reaction. We're going to see fever reaction quite a bit. This is just the body having a slight response to the blood coming in. The body knows it's not theirs and it's coming in. For any of these, if you think your patient has any type of blood reaction, you are going to stop the blood. You are going to flush the line or get a new line and only hang 0.9 normal saline. 0.9 normal saline is the only IV fluid compatible with blood. Very often, the physician's going to have the nurse give acetaminophen and Benadryl to reverse the reaction. You will actually see a lot of physicians giving Tylenol and Benadryl before a blood transfusion to actually stop the reaction before it happens. So it's very common to see that. If you have a patient that has a reaction, you are going to send that blood back down to the blood bank so it will be tested to make sure there was nothing abnormal about the blood. But the majority of the time, it is the patient just having a fight response to the blood. If we have a patient that does have a response to the blood, we would be very, very cautious on starting another unit of blood right away. That'd be a conversation to have with the doctor and the patient, and depending on what type of reaction that would be.